Okay, so today we'll be taking the pathology mock. The topic is basal cell carcinoma. So our first participant is Dr. O. So the scan goes a 70-year-old woman who is diabetic. He complains of shoulder pain and a tender scalp. Uh, she is supposed to undergo the temporal artery biopsy. While the temporary artery biopsy was being taken, uh, a skin ulcer was noticed over her cheek. Okay, I'm repeating. A 70 years old woman who is diabetic. She complains of shoulder pain and a tender scalp. She's supposed to undergo temporal artery biopsy. While the temporal artery biopsy was being taken, a skin ulcer was uh, noticed on her cheek. Okay, so I'll start a timer for 8 minutes. You'll get 8 minutes for 10 questions.
Okay.
So if you don't get a question, then
Yeah.
you can skip.
Okay.
Your time starts now. So what is your differential diagnosis?
Um, for, for the shoulder pain and the head pain, giant cell arteritis, and for the basal cell growth, uh, well, it could be a basal cell, a squamous cell, actinic keratosis, or seborrheic keratosis.
Okay, so assume that it is basal cell carcinoma. So
Yeah.
what would you see on bare eyes?
So you would see sometimes you see red skin around it, like with dilated blood vessels, and inflammation. Um, Telic, Jack, say, pearly papule with a central ulcer, granulation tissue, and sometimes rolled in edges. Yeah, this word telangiectasia is the proper word, isn't it, for the dilated blood vessels around it.
Okay. So can you please tell me the natural history of basal cell carcinoma?
It's normally slow progression. Comes over a few years, and it's limited to its local area and locally destructive, but doesn't usually metastasize.
Okay. So uh, assume that the examiner gives you a histology report. So the examiner asks, what will you look for in this histology report?
So you look for whether it's localized, nodular, cystic, pigmented, or if it's generalized, like a superficial, um, multifocal, or infiltrating the tissues around it. I heard this phrase ice pick, but I don't quite know what it means. I know they can say some basal cells have ice pick form. I don't know what that means though. Um, Nodular variants account for most of basal cell carcinomas.
Okay. So if you see that the margins are unclear, what would you do?
Um, well, if the
So,
margins are
so the
unclear,
specimen was, yeah, the specimen was resected, but after the
yeah,
histopathology report, the report shows that the margins were not totally completely cleared.
So you would probably have to go back and resect a little bit more so you get clear margins all the way around.
Okay, anything else
Would
you would like to do?
um uh perhaps if you look at the cell type, I think they say that basal cell carcinoma is ovoid cells. So maybe if you see it's basal cell carcinoma for sure, then you're less worried than if you worry it might have some other tissue type. Um,
Okay, so uh, if you see that there is a lymph node involvement, then what would you do?
oh, okay. So um, if there's a risk of malignancy and you take out the sentinel lymph node um, for examination, um, and then you would I don't know, perhaps you take out the first lymph nodes after that to make sure they're clear.
Okay, so what is frozen section?
Oh, it's when you take a piece of tissue, you put it in a
Hmm.
cold freezer for a few minutes, and it allows you to cut it very thin, and then you can stain it and look at it under a microscope.
Okay, uh, what are its advantages?
You can do it there and then while the patient, if you have a lab nearby, you can do it while the patient's on the table even. I've seen it done in like parathyroids. They can do frozen sections within a few minutes to check that, and then to check that they've got the right tissue out, and then, for example, take a blood test to check that the levels have gone down. So it's a very quick feedback test if you have a lab nearby that you can test it in.
Okay, so can you mention the steps of the frozen section procedure?
Yeah, you put it in a freezer for like 10 minutes till it gets hard, and then you put it in a slicing machine that cuts it up very thin, and then you put it on a slide um, with uh, some stain, and then look at it.
Okay, great. Okay, so because that you did a lymph node biopsy and there was lymph node involvement. So could you please tell me how did those malignant cells reach the lymph nodes?
How did those? Uh, they could have possibly been seeded when you did the excision because the knife cut through this layer of outer cells, and perhaps this let a few cells loose to go to the lymph node.
Okay, I'm not asking about after frozen section there was lymph
Yeah.
node metastasis or something. Uh,
Ah.
so j- with the disease process, how does that occur? How does malignant cells reach the lymph nodes within the
Oh,
natural disease process?
there's a growth factor called VEGF, I think, that um, that these tumors release that expand the lymphatic vessels so that the cells drain more easily to lymph nodes. Is that what you're asking about?
Okay, yeah, almost perfect. Looks your time's up.
Right.
So you took 8 minutes and you also completed all 10 questions. Very good. Okay. So in the exam under pressure, you'd obviously take more than what you will be performing here. So that's why time is given as 8 minutes. Okay, so let's discuss the answers. So the keywords here was the patient had shoulder pain and a tender scalp. That's why the patient undergone temporal artery biopsy because uh, the doctors was suspecting that it could be giant cell arteritis. But when the biopsy was taken, so the pathologist or maybe the doctor found that there is an ulcer over her cheek. So that's why my differential diagnosis would be the basal cell carcinoma, the squamous cell carcinoma, the actinic keratosis. These are okay. You can also mention tuberculosis. Then, if you have to describe what you saw, if it was a basal cell carcinoma, then you could mention there would be a central ulcer which has inverted edges and with granulation tissue on the base. So the papule itself is pearly papule and it has surrounding dilated blood vessels, which you call the telangiectasia. And about the natural history of basal cell carcinoma, it has slow progression and it is indolent and it is locally invasive. It's an important point to mention, and that's why it has limited potential to metastasize. So what would you look for in the histopathology report? So first, you have to look for if the margin is clear or not. This is the most important thing you have to look for. Then you would also need to look for the size of the tumor and also the invasion, how deep it has gone. Then if you see that the margins from the histology report is unclear, so you have to re-excise it with the safety margin and you have to do frozen section. That means immediately you have to do the frozen section and confirm that no more malignant cells are there. Or you can do the what it's called the Mohs micrographic surgery. Mohs is a name of a scientist or a surgeon or doctor. So from his name, the name came is Mohs micrographic surgery. Okay. And then from the histopathology report, if you are see that there is lymph node involvement or maybe clinically, then you would need to do the lymph node biopsy and it would confirm if there is the malignant cells in the lymph node or not. So if there is malignant cells in the lymph node, so what are the possibilities that could have been the way that the lymph nodes have the malignant cells within it? So it would be the cancer cells secrete the growth factors, which you said VEGF. I think it's VEGF. So vasoactive endothelial growth factor, I guess. So it would be taken up the capillaries within the lymphatic system, and these capillaries will transport the cancer cells towards the lymph nodes. So this is one thing. And also there would be some growth factors that would released from the cancer cells, which will induce the lymphoangiogenesis, and it would promote the lymph node metastasis. That means there will be formation of new lymph node, lymphatic vessels, and also the new blood vessels, which could promote the lymph node metastasis. And also the primary tumor would release some immunomodulatory molecules and these molecules are responsible for the immunosuppression. So immunosuppression is always a cause of, a more severe disease. So it can also lead to the malignant cells to transport to the lymph nodes. Okay, so we also talked about the frozen section. So what is a frozen section? You can answer it by in one sentence, that it is a quick laboratory procedure which allows for rapid microscopic examination of tissue to help diagnose a disease. So it can be a complete answer for the definition of frozen section. So it is a quick laboratory procedure that allows for rapid microscopic examination of tissue to help diagnose a disease. And what is the advantage of frozen section? You can also mention it in a sentence, that it helps in rapid intraoperative, that means within the operation, rapid intraoperative pathological diagnosis. And the steps of frozen section. So there would be the surgeon who will take a small piece of tissue from the tumor and will send it for analysis. The pathologist will freeze the sample and section it and will cut it immediately. Then the cut section will be stained and will be reported immediately, and just after that the results will come out and it will be informed to the surgeon. So it is all the procedures will be done when the operation is ongoing. So based on the frozen section, the surgeon will decide whether to excise more tissue or not. So this is intraoperative procedure. Okay, so these are all the questions from the session that you took. Okay, thank you so much. You performed very well. So I think, okay, I have another participant, Dr. Ahmad. Okay, so are you ready?
Hello, sir.
Hello, how are you?
I'm okay. How are you doing, sir?
Yeah,
Me too. I'm not
Alhamdulillah, I'm
that
fine.
good in pathology, so I'm just going to try.
Yeah, sure, no problem. Okay, so you'll also get the same topic. It's basal cell carcinoma. And the stem is the same stem. So let me repeat it for you. So a 70-year-old woman who is diabetic complains of shoulder pain and a tender scalp. She is supposed to undergo the temporal artery biopsy. So while the temporal artery biopsy was being taken, a skin ulcer was found over her cheek. Okay, so after the questions that were taken by Dr. O and all the procedures, guess that the resection was done, and also the skin graft was done. So after the skin graft was done, there was a graft failure. Okay, so what
Yes.
could be the possible causes of this graft failure?
So it could be immunosuppression. It could be seroma or hematoma. It could be surgical site infection.
Okay, so could you mention the common organisms for wound infection, if there is?
Staphylococcus aureus.
Any other organisms?
epidermidis. It could be proteus. Could be group A, beta hemolytic.
Beta hemolytic, what?
Streptococcus.
Okay. So how to do the diagnosis of wound infection
So
by investigation?
investigation, we can do incision and drainage. Then we can do swab culture and sensitivity.
Any other test?
Then we can do hematological tests like full blood count to look for leukocytosis. And we can do ESR and C-reactive proteins.
Okay. So antibiotic according to local trust policy was being given, but the wound is not recovering. So the doctors found that it was MRSA. What is MRSA?
So it's methicillin resistant Staphylococcus aureus.
Okay. So if the swab for MRSA was positive, then what did you do?
So I'll if the patient is on admission, I'll do incision and drainage. Then I'll do culture and sensitivity. Then I will take also blood culture here. Then I will also start the patient on vancomycin with the rifampicin and ticoplanin. Then linezolid will be the last option for the treatment.
Anything else you'd like to do?
Then for the patient,
The
I'll
patient
resuscitate the
is
patient.
what will you do?
I'll resuscitate the patient.
Okay. For safety of
Yes.
other patients, would you do anything else?
Yes, I will isolate the patient from the ward. Also inform the infection control team.
Yes. Okay. How to decolonize the MRSA if the patient is a carrier?
So we can give intranasal ticoplanin, and we can do this washout from the groin and the axilla to decolonize the MRSA for the patient.
Okay. Who will you involve in the management of MRSA positive patient?
So I will involve my consultant. I'll also involve the microbiologists, then the infection control team.
Anyone else?
Then for the wound, possibly I'll involve the plastic surgeon for reconstruction later.
Okay. So assume that the patient has developed lymph node enlargement, the axillary lymph node enlargement, and biopsy from that area was taken. So the histopathology report showed that there are large cells which has bilobed nucleus. It has prominent eosinophilic inclusion with nuclei that resembles the owl's eye appearance. So
Yes,
what is your diagnosis?
it's likely Hodgkin's lymphoma, non-Hodgkin's lymphoma.
So what are the cells?
It could be Ritz-Stambach cells,
It is found in?
non-Hodgkin's lymphoma.
Okay. So can you define carcinoma?
Carcinoma, it's a malignant tumor of epithelial origin.
Okay. And what is the features of this carcinomatous cells or malignant cells?
So they have the features like cellular atypia, increased mitosis, pleomorphism. Sometimes they have hyperchromatism and increased nucleus to cytoplasmic ratio.
Okay. So you answered all 10 questions within 6 minutes. That's impressive. Okay.
Thank you.
So I will be discussing the answers now. So the question was that skin graft was done after the resection, but there was graft failure. So what are the causes? So it could be wound infection. It could be due to hematoma that resulted in the rejection. And for the wound infection, the common organisms that we could encounter is the Staphylococcus aureus and the Streptococcus, and also the other micro organisms that you told were okay. What to do to diagnose this wound infection? So we have to do the swab for culture and sensitivity for sure, and also we have to do the white cell count and the C-reactive protein. So the WBC count will be raised. Also the CRP will be raised. And what is MRSA? In a word, in a sentence, you can say, you just can abbreviate it, like methicillin resistance, Staphylococcus aureus. Then what to do if the MRSA, swab for MRSA is positive? First, you have to have isolated the patient and also informed the infection control team, and you have to follow a protocol that's called the infection control protocol. So these are three most important things you have to mention if the patient is MRSA positive, because you have to look for other patients also, because it can get spread and then it would be hazardous, it would be epidemic. Okay, then if you have to do the own debridement, and if there is an abscess, then you would also have to do the incision and drainage. But in this case, you need not do the culture and sensitivity again, because you have already done it and you have found that the patient is MRSA positive. So just incision and drainage would be sufficient. Then you would give antibiotics. Try not to mention the names of the antibiotic at first. You have to always mention that I will give antibiotics according to local trust policy or local trust protocol, or according to microbiology report or microbiology advice. So your answer should be like this. And then if the examiner asks that what specific antibiotic you'll need to give, then you can mention the vancomycin, teicoplatin, whatever you have told. Okay, and to decolonize MRSA, if the patient is carrier, then we all know we have to use the mupirocin nasal drop. And another thing is we have to do the give the chlorhexidine body wash or chlorhexidine shampoo. And for this MRSA positive patient, we have to involve the ward nurse, because they are very important to maintain, because you'll not be always there. The ward nurse will be always there. So ward nurse then the microbiologist, and obviously the infection control team. They are required. And then the patient developed axillary lymph node enlargement, and the biopsy taken, it showed large cells with bilobe nucleus with prominent eosinophilic inclusion, and the nuclei resembles owl's eye appearance. So my diagnosis would change to Hodgkin's lymphoma. And Reed-Sternberg cells have the appearance of owl's eye, and it's Hodgkin's lymphoma. You missed on that. And carcinoma, yeah, you can mention within a few words. It's a cancer that develops from epithelial cells. And the features of malignant cells are abnormal mitosis, increased number of the mitotic figures, then hyperchromatism, which is the condensation of the chromatin, making the nuclei darker. Pleomorphism, which is the variable size and shape of the cells, the tumor cells. And the nucleus to cytoplasm ratio will be increased. So it could be 1:1, I guess, or the nucleus might be a little more larger. Okay, so this is all about this station that you performed. Okay, you did great. Thank you so much for participating. Okay, so let's see if we can find another participant for this station. Anyone wants to participate? You're welcome. Anyone? If no one wants to participate, then we will end this session here. Anyone wants to participate? I think a few people just joined. So anyone from you want to participate? The basal cell carcinoma station?
Okay, I can.
Okay, great. So you are Dr. Isra, right?
Yeah.
Okay. So it's the same station, but there will be some a few different questions. Okay. So this is the same station, which is basal cell carcinoma. I'm reading this stem. A 70-year-old woman who is diabetic complains of shoulder pain and tender scalp, which has been for about a week. So the patient is supposed to undergo the temporal artery biopsy. So while performing the temporal artery biopsy, there was a nodular lesion with some ulcerations over her cheek, and this is suggestive of the basal cell carcinoma. So a 70-year-old woman who is diabetic, having shoulder pain and tender scalp for 1 week, is supposed to undergo temporal artery biopsy. While performing that procedure, there was a nodular lesion with ulcerations over her cheek, and it's suggestive of basal cell carcinoma. So, okay, so you'll get 8 minutes for 10 questions. Your time starts now. Okay, so in this patient, why the temporal artery biopsy was taken?
To exclude or to diagnose giant cell arteritis.
Okay. So what is the usual medical treatment that should have been started before the biopsy is taken, before the temporal biopsy is been taken?
Yeah, corticosteroids 60 milligram once oral, and or if there is amyloidosis, Fogax, or visual affection, we will go for 80 milligram uh, of injectable steroids.
Okay, good. So why is it done before the biopsy has been taken?
Sorry, why what?
Why the steroid therapy needs to be started before the biopsy is taken?
For fear of affection of ophthalmic artery that gives a retinal artery, which is end artery that may cause affection of the vision.
Okay. So assume that you have got the pathology report. So mention 4 data that you would look for.
Internal elastic lamina fragmentation with lamina propria infiltration with lymphocytes. This is the
Okay.
form of granulomatous inflammation.
Okay. So what features you would actually look for? Like what data, like what titles or what subjects you will look for in the pathology report? Not the
Uh,
findings.
mhm. For the safety margin and the depth of
Yeah.
invasion, and if there is invasion for the lymph node or vascular invasion.
Okay. Okay. So what could be the feature uh, that would make you concerned that there is a risk of metastatic disease? What are the features?
Features if there is affection of the basement membrane, then local invasion of the underlying structures. If there is lymph node positive for tumor cells with malignancy symptoms like malignancy characters like hyperchromatosis, pleomorphism, or increased nuclear cytoplasmic ratio, increased abnormal mitotic figures.
Okay. So 6 months later, the patient was being readmitted following a fall. So radiology report revealed that there was a neck of femur fracture, and the patient underwent surgery. So what factors could have the predisposition here?
For this case, this is immune compromised, and there is the patient is on steroid and old age, post-menopausal female.
Okay. So in this patient, in this fractured patient, uh, the serum calcium and serum phosphate level, what do you expect it to be?
Serum calcium,
And serum phosphate levels?
mm, normal levels.
Okay. So when the surgery was done, so during the surgery, the bone matrix was soft and fragile. So the surgeons sent a sample from that bone matrix to the histopathology, and it revealed myeloma. So what will you find in this myeloma?
Plasma cells proliferation.
Okay. So what does myeloma secrete into the serum?
Um, in the serum,
Yes.
Benzgens, a protein in urine. But I don't know in serum.
Okay. So you mentioned Bence-Jones protein. What is it?
Benzgens protein. This is a protein arises from the bone marrow, and it is byproduct of destruction of B lymphocytes.
Okay. So you took 7 minutes and you finished all 10 questions. That's great. Okay, so let me discuss the answers for this system. Okay, so in this patient, why temporal artery is being biopsied? The cause is because we have the suspicion that the patient has giant cell arteritis. As the patient has tender scalp, that's why we suspect that the patient might be having the giant cell arteritis. And that's why before taking the temporal artery biopsy, we just start the large dose of corticosteroid. And the reason why we do it is because we fear that there would be involvement of ophthalmic artery from the arteritis, from the giant cell arteritis. So from giant cell arteritis, there would be ophthalmic artery involvement causing the ophthalmic arteritis maybe. So there would be ophthalmic artery involvement, and it could make the patient blind, or there would be a problem in the vision. So it could involve the central retinal artery, which is an end artery, causing the blindness, which could be temporary or permanent. Okay, so to protect vision, we do the large dose of corticosteroid before taking the biopsy, because it could be late while we take the biopsy. So we have to start as soon as we suspect that thing. So the patient had a large dose of corticosteroid, we can assume. So if the patient is having a fracture due to a normal fall, then we can suspect that this is osteoporotic fracture, and the reasons or the predisposing factors could be the patient is 70 years old, that means old age, female, postmenopause, and the history of corticosteroid, large dose corticosteroid intake. Okay, and in this case, osteoporotic fracture, the serum calcium and phosphate level will be normal. So there will be normal bone mineralization, but the bone density will be reduced. Okay, so in the pathology report, the things that would we see is what is the type of tumor, what is the diameter of tumor, what is the thickness of tumor, and most obvious thing, to see is if there is unclear margin or not. You have to see both the deep margin and lateral margin clearance. Then the fact that raises the suspicion of it being a metastatic disease is that the presence of blood vessel invasion or lymphatic invasion. So it could lead to metastatic disease. So you said basement membrane invasion. Yeah, that could be another cause. But for a metastatic disease to occur, it needs to be spread through blood or lymphatics. And okay, so from the histopathology report of bone matrix, there was myeloma. So it is so in this I will find the neoplastic and monoclonal proliferation of plasma cell. So it is a monoclonal and neoplastic proliferation of plasma cell. So abnormal plasma cells, not the normal plasma cells. And the myeloma will secrete into the serum, which is called the immunoglobulins or the fragments of immunoglobulins. This will be detected in the serum. And the Benz-Jones protein is a light chain paraprotein, and this is identified in the urine. So in serum, we'll get fragments of immunoglobulins, and in urine, we'll get the light chain paraprotein, which is called the Benz-Jones protein. Okay, this was all about the basal cell carcinoma. It covers almost all the questions that could come up in the exam. Okay, thank you everyone for participating, and Dr. Isra, you did perform very well. And the session is being recorded, and I plan it to upload in the YouTube, and I'll be sharing the link, inshallah, in the group or in the channel. Okay. Thank you so much.